We are. End of day 3, almost. So it's always a pleasure, and it's a pleasure again to invite to the podium Dr. Alfonso Iorio. He's going to talk to us about clinical decision making, how to communicate to patients risks and benefits. Alfonso.
Okay. I see a lot of survivors, which is always good. And don't worry, this is not certainly the talk that's going to kill you. But we have a few important final remarks to make. After you have done all your due diligence and you now know the evidence and you have asked the appropriate question to the patient to understand what he prefers, you know what the cost implications are and so on, there is still one last step, which is being able to communicate the decision in a way that the patient understands, and also to communicate the risks in a way that the patient can make a decision about what to balance. There's no way you can have an informed decision if you don't understand what the matter you are deciding about is. So a few concepts about medical literacy, communication skills, and shared decision making. And really, medical communication is key. There is progress in the way we do research. There are new methods coming up, new study design, but really the progress of science in methods is very slow, while the progress and the need in improving communication is still very high. So on this side, there's a lot of work that can be done. And the problem is that we are doctors, and politicians are politicians, not statisticians, not mathematicians. And unfortunately, you have been flooded by numbers over these 3 days, because numbers are the most synthetic and effective way of representing the result of studies. So we have to find something that links evidence to what we can understand. These are the results of a survey done in Europe to check the understanding of concept around screening. And you see that the results are very, very bad. This is the score on a questionnaire investigating about concept around screening. And you see that the understanding among, in this case, among physicians was very, very low. I'll take an example not from the healthcare world. You may recall Rudy Giuliani. Rudy Giuliani couldn't stand up for the second mandate as a mayor of New York because he was diagnosed with prostate cancer. But he showed up during the campaign of the mayor who took over from him, from his own party, to support him. And he made a statement like the one you see on the slide. He said, I had prostate cancer 5-6 years ago, and my chances of surviving prostate cancer, and thank God I was cured, in US, 82%. If I had been in England, only 44%. That's the effect of socialized medicine. He was clearly not in the Obama party. Now, why survival in the States is 82% and is 44% in UK? Is really because UK saves money on screening? Do you know the answer? Well, the answer is on the screen. I will ask you less questions, it's late afternoon. But if you don't do that, let's assume the cancer is developed here. So you develop cancer at the very beginning, and then time lapse and US is below. At age 60, you get the screening and you get the diagnosis. And you survive until age 70. So you survive 10 years. In UK, you don't do screening. Cancer starts at 50, same time, and becomes symptomatic at age 67. And you die at 70. So yes, survival is less in UK. From the moment of diagnosis to death is 3 years. In the States, from the diagnosis to death is 10 years, but you still get cancer at 50, and you die at 70. So there is no difference in reality. What happened with screening? Well, in UK, 10,000 develop cancer that will progress. Some of them progress, and of those who progress, 440 are alive after 10 years, and 560 are dead. 44% survival. In US, same thing. 1,000 cancer would progress over 5 years. Of those, 560 are dead. With screening, you pick 2,000 more cancer not progressing that will still be alive later on. And so if you count all these that would not progress, that would never know that they have cancer, and you screen them, you find the cancer, they all remain alive, but survival become 81%. But those dead are 560 in both places. So you change the survival rate just because you make more diagnosis of milder disease, non-progressive disease. Screening does not affect care unless there is a viable treatment. For prostate cancer, the few aggressive cancer, we have no treatment. The vast majority of cancer, they do not require treatment. So in the States, you do the diagnosis and then you wait. Yeah, you take away the lesion, maybe, but you just wait. You don't do chemotherapy. You may do hormonal therapy in a subset, and so on. Now, this is not, yeah, thank you. Thank you. So, but the perception is in UK, your chance of dying of cancer is much higher. Survival is 44, in the States is 81. By the way, if for the same intervention, if you present survival rate, 83% of doctors, they get that there's a large benefit as to mortality. If you present mortality rates, which is exactly 1 minus, 81 survive, 19 die. If you say how many survive, the common understanding is, oh, this is really affecting mortality. If you present mortality, many less understand that there is a gain in terms of survival. If you say survival goes from 80 to 85, say, wow, that's a powerful intervention. If you say mortality decreases from 20 to 15, okay, not that good. Only 5% impact on mortality. Well, the other one was the same. Just raise survival. It's a matter of how we perceive, is the glass half full or half empty. Depending if I say half full or half empty, more or less people will feel we are running out of water or not. So, and the same is 3 different ways of saying the same thing. Screen-detected cancer have better 5-year survival. 76% of doctors say, okay, that's a good news. More cancer are detected in the screening population. 1 in 2 doesn't know. What does that mean? Is good, is bad? I don't know. Third way, mortality rates are lower among screened person. Oh, that's good. Is the same. I showed you UK, US. There is no difference. Same number of people dies. But if I focus only on a detail of the intervention effect, I get a different feeling. So if you frame a survival rate, 79 judge the screening effective, frame at mortality rate, only 5% judge the screening effective. If I ask you what's lead time bias, who knows what lead time bias is? No one? Come on. At least 2 in 75 in the survey in Europe, so hopefully. Lead time bias is exactly what I showed you that happened in UK and US. What the difference is the time between diagnosis and death. That's a lead time. Overdiagnosis. Who knows what overdiagnosis is? Overdiagnosis is exactly what I showed you for UK and US. You diagnose those 2,000 mild cancer who are not going to progress. With screening, you tend to diagnose milder state of disease who will never progress beyond. You know that even prostate cancer screening, I don't know if you do it here, is being abandoned. Doesn't affect mortality, doesn't affect survival. So it's not really worth doing unless you have symptoms, unless you are in a family with risk. Even breast cancer is questioned, is challenged, because it's not really impacting on survival of the population. Lead time bias, overdiagnosis. Now, if you get in the mail a questionnaire about what these are, please say you know. Even if you don't recall exactly what, but at least you heard once about lead time bias. Now, one of the stream of research in EBM focused about communication. And Gigenzer and Schwartz in Austria and Switzerland, they worked on fact box, easy way of communicating to patients and also to doctors about risk. If you present data this way and you say, okay, we compare no screening with screening, what happened? And you start saying, in 1,000 men, how many died from prostate cancer? 7 and 7. How many men died from any cause? 210 in both groups. And then you say, and that's for benefit. So the benefit really, if you present it this way, you get it. No matter if it's US or UK. I screen, 7 deaths. I don't screen, 7 deaths. Overall, 210 deaths. Up to year screening, no good. Then you proceed, arm. Okay, how many men without cancer were alarmed by a false biopsy? Well, if you don't do the screening, none. If you do the screening, 160, they got a borderline biopsy and they had to get for a second assessment and so on. And how many men were treated, diagnosed and treated for cancer without need? 20, because in the end there was no cancer or a form that would have not progressed. And then there are complications, because you say, well, okay, it's fine. Bit of complication here. Do you know what's the rate of sexual impotence after surgery for prostate cancer? It's sizable. So, didn't happen to Rudy Giuliani, but you might not have a gain in mortality, not a gain in diagnosis, actually false positive, and also have complication. So if you present this way, it's easier to understand. If you present this way, I don't know why these lights are so pale today, but if you look at no screening and screening, those with cancer are the same, the dead one are the same. Sorry, the dead for cancer are the same, the dead for other causes are the same. In the screening group, you also have false positive and you have patient with complication that you don't have here. Of course, if you had less red with screening, you would say, okay, I have less red here. But if you have the same mortality and only complication, it's not a difficult decision when it's displayed this way. Now, I'm using a case where there is no difference. But even if there was a difference, I would see it here. And I would see how many gain for how many complication. So always put benefits and harms. Use the same denominator, possibly 10, 100, 1,000. Report the means in the two group. Don't use confidence interval. Confidence interval are good for physician, are good for us when we play with the identity line and we put the studies up and we look for precision. But confidence interval are not good when you talk to patient. Don't say what's the range of probability is. You may say what's the confidence is, but it's already complicated with one number. If you put variability around, becomes non-manageable. And be clear on what can happen, simple and clear. Don't mix up stuff. Don't use relative effect and absolute number for risk. And don't say the effect in percent and the harm in per 1,000. Shouldn't be in papers, but usually journal editors do very bad job. So you find, usually in the abstract, you have only positive effect. You'll never have harm in the abstract. And you usually have the reduction in stroke was 50%. There were 5 bleeds. Come on, don't tell me 5 bleeds, or tell me I prevented 5 stroke and I had 5 bleeds. Use the same unit so that I can easily match. If you tell me that the relative risk reduction was 50 and there were 6 bleeds, then I have to say, okay, how many strokes and reduce to how many less, and that's what I compare with the number of bleeds. Let's use the same number on both sides to make it easier to understand. We don't do it. There's a book, Better Science, Better Patient, Better Decisions, from Gigenzer, that covers all of these very, very nicely. And is printed in black on white, not like this slide. So, if you take home messages from the entire course, it's difficult to get what you need in one single paper. Maybe in a meta-analysis, but very often you have to rely on different articles. One will tell you about a diagnostic test, and the other one will tell you about a treatment. That's why guidelines are usually better, because they put all this stuff together. They try to answer questions that are clinical practice questions, so they already have looked for the various components. We are interested in bodies of evidence, the evidence needed for a clinical decision, not in individual studies. We appraise individual studies, but then we have to put all together. Prevalence, diagnosis, effect of treatment. We need all of them. We have learned, I hope, over these 3 days that the study characteristics for the different scopes are slightly different. The backbone is the same, but they are differently beefed up. Always prefer systematic reviews. I have told you this to the nausea, but you save a lot of reading time. It might be a bit more complicated reading a systematic review until you get to understand forest plot like traffic lights, but as soon as you are at that level, as you can cross a crossroad, you can read the systematic review. Systematic reviews are not perfect, of course. It can be that the conclusion of a systematic review is not confirmed by a subsequent trial. New England, they don't publish systematic review by editorial policy. And the only issue they published in 1997, all on systematic review, was to show that really, when you have, they took 40 cases where the systematic review was showing an effect that no one of the included studies was showing. And so they said, well, you have no single trial that proved that there's an effect. Only by pooling them, you see an effect. In those cases, usually, there is someone that says, okay, let's check it. Let's do a large trial and see if it confirms. So they found such 40 cases, and they checked how many times the 20 systematic review that were positive and the 20 that were negative were confirmed in trial. This is like a diagnostic test. So positive, positive. Actually, what are we interested in is positive, positive, 13 cases of confirmation of positive message, and 14 of negative message. You can calculate sensitivity and specificity, and you'll find that the systematic review was 65% sensitive and 70% specific in predicting the result of a subsequent study. Now, this morning, Joseph told you that 65 for a diagnostic test is really bad. Well, not here, because here it says you that in 7 cases out of 10, the result of the systematic review were what the study would have later on confirmed. So 3 in 10, they were reverted. But in all the other cases, they were confirmed, which means, in general, they are good evidence. This is not dead bodies or wrong diagnosis. We all know that science can always change, no matter if it's a systematic review or a trial. What we all wrote in response to this is, have you ever tried to calculate what's the predictive value of one trial for the following trial? Is a deadly 50%. There's no way you can be better than chance when you try to predict one trial with another trial. With a systematic review, you do much better. You are 70%, both for sensitivity and specificity, which is pretty amazing. Okay. If you didn't understand the concept of checking your patient against the inclusion criteria of the study you are reading, you are hopeless. There's nothing we can do more than that. We have told you that to the desperation, so please do. Clinical trial, particularly those ending in New England, phase 3 trial, the one that show for the first time that a drug is effective, are usually selecting a very, very specific population. So the more the trial is internally valid, the less will be applicable. For external applicability, we like pragmatic trial. Look for absolute risk estimates. What you need is how many patients I need to treat, more than relative. A relative risk, first of all, you have risk ratio, odd ratio, hazard ratio. You're now very familiar. You know where to cross the road when you walk, even if it's a trafficy road. But what you need in the end is an absolute measure of risk. What's the difference in terms of event? It takes time. Assessing the quality of a paper takes time. So if there are sources of pre-appraised evidence, if you know already that there are collection of good articles, then use them. This is a very biased statement because I'm going to tell you what we do to pre-appraise evidence and make it available. But before going there, beware that the best agency to do knowledge translation are pharma companies. I don't know if you are visited here by pharma representative. That's a form of knowledge translation, very effective. So they come to you with a paper and they try it, or with a box of a medication, and they tell you how good that is. That's knowledge translation, not necessarily EBM-based knowledge translation, but is knowledge translation. And why it works? Well, because it makes it easier. They come to you anticipating your question and trying to providing you answer. That's again what we try to do. We try to invite you reading only those papers that very likely you will adopt in your clinical practice. I showed you already my research unit. I'm telling you now what we do very, very briefly. It will not take after 8 p.m. or so we'll be quick. I have a few slides. So we go through a process where we start here and we read 120 journals. Which journal it changes, but we can read 120. We read New England, Lancet, BMJ, Annals, JAMA, down to subspecialty journal. We read them and we select good papers. We take care of quality. I will show you in a second the criteria we use, but we say, okay, this paper on treatment is good. This one is bad, this one is bad. And the same we do for diagnosis, prognosis, and so on. The papers that are good, we appraise. So we decide if they are interesting for cardiology, internal medicine, neurology, pediatrics. We add details about the population included, adult, young, kids, both. We attach a scope, prognosis, treatment, diagnosis. We attach an indexing by disease. This is diabetes, this is hypertension, this is angina, and so on. We do all of these in about a week, so much before these papers are indexed in Medline. When we are done with this step, many people are involved. A reader, an indexer, a librarian, there is a clinician that reviews all the job, and then we send this paper out. We have a network of about 8,000 people working with us. They do it for free, they get credit. You can register to do it if you want. The only requirement is to be in clinical practice, and you have to declare your discipline. And you have also to declare how many articles you will receive. You may say 1 per month, or you may say, I want to read 1 per week. And we'll send you articles that were selected in your discipline. So if you are an internist, you will receive internal medicine. If you are a pediatrician, you will receive pediatrics. We send each paper to 5 people in each discipline that paper was selected for, and we ask them 2 questions. One is this relevant? The scale is 0 to 7, and the answer is no, I will never use these, to 7. I'd likely use these in all or in most of the patient eligible for this treatment, for this medical intervention. And there are all the flavors in between, some, none, and so on. That's relevance. The second question we ask is this new? And 0, everyone knows already. Why the heck are you sending around this paper? Well, I don't know, it was published on New England, and I'm not an expert in gynecology, where are gynecologists, there were some around. So I just need to ask you, the paper is methodologically correct, was on New England, but you tell me if it's new or not. And you can tell me no, everyone knows already in my discipline, or you may tell me, well, I think that you would not know if not reading this paper. That's a 7 for us. We get back these scores, we do the average in the discipline, and then we retain in the database only those that are 4 or more. And we keep the score. And the raters can also add comments saying, oh, finally a paper telling us what to do in this situation, or well, it's a nice confirmation, much larger study, this is the value. In this comment, we clean to be sure that there is nothing offensive for anyone. You know, sometimes doctors, they are not so polite when they judge other people's work. And then we publish the comment as well. So this is all available for free. Before I show you how you can get this, the criteria, they are published on the website. So on this website here, or this one, hiru.mcmaster.ca, Hiru, you'll find all the rules we use for appraisal. These are exactly the rules that we have used these days. So for a paper on treatment, we want random allocation, we want more than 10 patients per group, at least one outcome assessed in more than 80%, no attrition, pre-planned subgroup analysis, and so on. For etiology, we want sum odd ratio, we want concurrent comparison, inception cohort, early stage of disease. For prognosis, we don't want referral center. And so we apply exactly the rule that you have been working on. We have rules for diagnosis and so on. For diagnosis, more than 100 patients, a spectrum, at least 50 with the disease and 50 without. There should be a gold standard. The assessor has to be blind. So you won't get a paper through this system if it has any of the flow that we have been discussing these days. You'll get them for free through a system two ways. One is this one, evidence alerts. You can go up there, plasmcmaster.ca evidence alerts. You get to this page. It's free. You can register. And I'll show you in a second what you gain by registering. You get alerts. So you can register to receive in your email the articles selected with your criteria. And you also have new articles, so you can go in on the website. If you may read the email you receive, or you go here, you read the new one, you can save the one that you find interesting and you think you might want to go back to. And you can also see the one you had received, or the one that are most read by your peers, or the one that got the highest score, all one click apart. This is device responsive. No, this one is not device responsive, will be device responsive in a month. So ideally, I see that you prefer to read on mobile. It should reframe on a mobile. Now, when you register, you are asked if you are a doctor, a nurse, a physiotherapist. It's not just because we are curious. We try to give you what's most relevant for you and which discipline you are in. So you can specify, and you can change it all the time you want. You can say, I'm a vascular surgeon, I'm an internist, I'm an hematologist. After you have specified your discipline, you say when you want to receive the alert, every day, every week, every month, and you say your cutoff. And there is a simulator that tells you, okay, if you say that you want to see all those 6 and above and 6 and above, and you are an internist, you would receive about 20 per month. Whoa, 20 per month, we'll never read 20 per month. Let's try something different. And then you say, okay, let's send me only those rate 7 for relevance and 6 for newsworthiness, and then you receive 4 per month. So you can play with relevance and newsworthiness. Maybe in neurology, no matter how you set these, you will receive only 1 or 2 per month. But are those that might likely make a difference in your discipline? We might not read all the journals for urology, but if there is a paper in urology that makes it to one of the major journals, it will come through this one here. So that might be a good combination for a specialist. You read your journal in radiology that we don't read, but you'll get good stuff that comes up on all the other journals. You don't need to worry about what gets on the other journal. One other way we offer this content is a searchable. Evidence alerts is more set up for those saying, I'm never going to search any literature. I like to receive something in my email, and then I'll decide if I have time or not to read. If you are more on, I search when I need, then go to this website. Again, it's free. plasmcmaster.ca, in this case, not evidence alerts, but access with 4S. I know it's not nice to pronounce, and I don't even recall anymore what the 4S stands for, so I need to change it, but for now, that's the way it is. You search for something, in this case, clopidogrel acute stroke, and you find, in a few seconds, it compiles for you this page where you have where to go in DynaMed Plus, where to go in UpToDate. Even if you are a UpToDate user, you will likely find better where to go if you go through this system than directly in UpToDate. And you have 3 chapters. You can click on more. You see 52 other chapters where there is something about clopidogrel and stroke. You read a couple. If you don't find what you need, you can go down. And here you find American College of Physicians Journal Club abstract. I'll show you one in a second. And if you continue down, you'll find the articles in Evidence Alerts, the one that were rated, with the scores and the comments. And down here, you find already PubMed searched through the clinical queries. You might have seen these in the literature search exercise, but if not, if you know what clinical queries are, instead of going to PubMed, put in your string and search clinical queries. Here, you go from Dynamed, UpToDate, to clinical queries already searched with all the categories. If you use the clinical queries, it separates systematic review, therapy, diagnosis, clinical prediction guide, prognosis, and so on. And if you click of any of those, let's say you want to go and see the American College of Physicians Journal Club. By the way, you find here the Wong article that we read on adding clopidogrel to aspirin. That was a good study in our opinion, and when it was published, we thought was good to broadcast to the American College of Physicians. So we created an abstract. You see, these are the rating: family medicine 6 in 7, emergency medicine 7 in 7, hospitalist 6 in 7, neurology 7 in 7. And then we have prepared one pager where you have the abstract, one column, all the studies summarized here always the same way. The design, allocation, blinding, follow-up, setting, all the questions that you had to answer, we answer for you, are already here. You can save to read the article. You read this column. And on the other column, there is a comment from an expert who helps you understanding what's new in this paper. We don't do this for every single article. It costs about $1,000 to do this one here and publish it on Annals. You need to have access to Annals, so I don't know if you have access to Annals of Internal Medicine through Kim. If you don't, you can't read this one. But if you have access, we do 100 per year, and you'll get the link in your mailbox if you register. Here how it looks like in a bigger frame. Now, you can have an advanced search. So you may go in and say, I only want to search what you had considered relevant for cardiology, for primary care. I only want to find article on diagnosis. I'm only interested in pediatrics. I only want review. So if you want, you can filter to what your specific need is. And you can go in and if you prefer to have only one stop shop, instead of registering on Evidence Alert and searching here, you can use this one to search, and you register here. You get the same alert you would get through Evidence Alert through this system. So you go in and you'll find the same way where you say your discipline and you decide how many you want to receive. And you can have hit parades of the one that you receive. Now, that's for free, and it's completely under our control. So if you want to, I would recommend you try it, particularly those that were using Medscape or other alerting system. This is non-sponsored. If you use it or not, I don't make any more or less money. There is no advertising. We do these, how we maintain, I'm happy to tell you, it's not cheap. I mean, I have 13 staff and are not hired by university. I pay their salary. So I need to have income. I sell this content to publisher. I sell this content to EBSCO. I sell this content to the Norway healthcare system a network of libraries in Australia. Finland buys it for embedding in their healthcare medical record. Harrison Internal Medicine buys it. Ovid, Walter Kluwer, they don't officially say that they use it for up-to-date, but they buy it for a free literature service they have. And we get enough money through this system to do some research and to pay salaries of staff. So it's already paid for. I don't make any more money if you use it. But I'm happy for you to try it, because we have about 50,000 registrants, and we have about 24,000 people clicking on the email and coming to the database. And that, to us, is a sign that we are, is good. You get good stuff. If it's not good, let us know. If we send you as a surgeon or as a cardiologist something that is not for you, tell us back, and we will improve by learning. But we think that is a good way of keeping your learning skill up, because you read good literature and you are exposed to a set of well-designed studies. Then it's like getting used to commodities and high-end lifestyle. As soon as you miss your stuff, then you feel, oh, this is not as good as usual. And you recognize bad studies just by gut. The best way to learn how recognize good literature is continue to read good literature. We select about 3,000 articles per year out of 60,000 we read. So we cut down by an order of 20. For each discipline, we select, depending on the discipline, from 5, 6 articles per year to 20, 25. Even if you read them all in your discipline, they are not a lot. Of the 3,000, if you are a pediatrician, an internist, a neurologist, is a small subset. It's the cream of what you could read. I strongly recommend you try it. If you don't, we can still be friends. And with this, I'll thank you for the 3 days, and I leave it to Fahd for final housekeeping and all the rest. Thank you.